school in Utah State, where he did a double major in chemistry and liberal arts sciences. And then he came to the University of Utah for medical school. Afterwards, he did residency and fellowship at the Mayo Clinic before coming back to Utah at Intermountain Healthcare, IHC. And he was there for a dozen years or so before a few years back. We were fortunate enough to recruit him here at the University of Utah, where he's a full professor in cardiovascular medicine and electrophysiologist here. Jared's done amazing work. A lot of the work that we have about atrial fibrillation and dementia and some of those associations are directly due to his work. He's an author on more than 200 manuscripts, original manuscripts. And especially for how long he's been out there, that's an amazing productivity. And a lot of those are excellent journals, these findings and publications. And just on a personal note, years ago, I didn't meet Jared, but I met his brother, David, was a missionary companion of mine in Uruguay 25 years ago. So before I knew Jared, I knew his brother David in Uruguay, of all places, a little city called Chuy out in the middle of nowhere. We lived together for a couple of months there. But we're really glad to have Jared, and I'm excited to see his work here. Thank you.
Thank you. Thanks for that kind of invitation. Yeah, he met the better half of the family 25 years ago. It's a pleasure to talk to you and be invited and also to collaborate with many of you. I've had that opportunity almost immediately working with Robbie Ranjan, and so it's been a pleasure. And I was asked to speak a little bit on our work that we've done in atrial fibrillation, stroke, and cognitive decline. And some of you have been instrumental in that. And we have a paper, hopefully, being reviewed favorably by Jack EP on some of the canine work that was done here just recently. And I'll show some of that. And Brian Singer gets a lot of the credit for that, for his perseverance. But these are important disclosures for this. These are institutional grants I've received, but all of these have some interest in anticoagulation, stroke prevention, or rhythm management. So they're relevant for the talk, but there won't be any unlabeled interviews discussed today. So I want to talk about atrial fibrillation. Now, I live in this space, so this is very familiar, but if you're not, you don't quite, may not be aware of how prevalent it is. And we know it's common in our community. We know if we live to be over 80, 1 in 3 of us will get it, over 90, 1 in 4 at least. And we know that it's increasing in the community and is expected to do so as risk factors such as inactivity, obesity, hypertension increase. But also when we account for those, there's more increase, there's a higher risk that we can't fully account for. But what's also coming to play is this is historic data, and now we have the ability to detect atrial fibrillation with direct-to-consumer products. So we're expecting what the diagnosis is going to be about 30% higher than we projected based upon early diagnosis and self-diagnosis. And I need to update this. Yesterday, Google had showed their new watch that's been approved for FDA diagnostics as well. And so we're pushing this a little bit into the hands of the people for diagnosis, and we see that a lot in our clinic. But what we do know, and this is Framingham data, and it's looking at 10 decades over time, and it needs to be updated for the last decade. But what happened, the lifespan with atrial fibrillation at the time of diagnosis is quite poor. In fact, in 10 years, only about 1/4 of our patients will be alive. And despite changes in medications, therapies, devices, the survival changes have been very modest. And most of this is due to stroke reduction. So we have a lot to do to understand what we can do early on for this steep loss of life here, and can we mitigate this risk over time in men and women. At the same time, we have ongoing risk of in westernized countries of other things that are driving mortality. And in fact, most of the mortality in the United Kingdom is related to 3 things, and that's dementia, stroke, and Parkinson's disease. And that's increasing substantially. So As we get better at managing cardiovascular disease, we transform mortality and type of mortality more to the neurocognitive domain. So we have two escalating problems in our community: atrial fibrillation and neurocognitive dysfunction. And we've looked a lot into this, and most of the time we spent looking at the role of clinical and subclinical strokes with atrial fibrillation. These have been well documented for over 100 years, but we're starting to explore what about small events, clinical and subclinical bleeds, repetitive microbleeds and clot, the role of cerebral hypoperfusion and hypertension, and how does that interplay with atrophy, volume loss, genetic predisposition, amyloid plaques. And we've started to try to understand the brain better in atrial fibrillation, going beyond macro events to some of these other things. And what we know is whatever happens, happens early. So these are neurospecific markers that typically are only available and detectable in the brain when there's been disruption of the blood-brain barrier. And we paralleled work from the NFL years ago and took these markers and looked at patients at their first diagnosis of atrial fibrillation throughout Utah. And we found that in all markers, there was a small but reproducible increase in these markers of brain injury in patients with atrial fibrillation compared to controls. So we know that when they come to clinic, it's already at a time in which there's injury present. And I think there's exciting new data that help correlate this initial finding and some of the work we've done. But also when those are present, when those markers are present, we can also measure elevation in antibodies. And those antibodies, their presence and their level tend to associate with risk of cognitive decline, whether it's a marker of how much injury was present or whether it's active in the process, we still have to understand. But these antibodies of neural injury are present in our atrial fibrillation patients. And one of the challenges we faced with atrial fibrillation is the contemporary view of electrophysiology, and really what we've sought to understand and what have been our risks, what have been our endpoints for all of our studies. So these are some of the largest studies in electrophysiology over the past 5 years. And this is the Cabana trial, which is the largest trial of rate versus rhythm, of ablation versus rhythm control with medication. And the endpoint was disabling stroke. And when you get a bunch of neurologists in a room to agree on what's a disabling stroke, it's really hard. And so this whole trial of over 2,000 people for 5 years of follow-up, there were 16 strokes that everybody agreed upon, which vastly underestimates what was happening. This is our most recent left atrial occlusion trial, these devices that go into the appendage and are an option for patients that can't take anticoagulation. And they used ischemic stroke in a secondary stroke or TIA of all forms. And then the most recent anticoagulation trial of apixaban versus warfarin, again, clinical stroke with focal neurologic deficit. So our view has been really on macro events with clear, measurable disability. And trials are going to highlight that that's probably not the best way to look at these patients. This is data from the Swiss AF trial. I've been involved in this trial early on. I was asked to review it for their NIH equivalent in Switzerland as a government-sponsored grant. And what they did was take everybody that had atrial fibrillation and they agreed to enroll, and they had a baseline MRI. And when they came in, 20% had a prior unknown small stroke, large stroke, had the presence of microbleeds, and also nearly all of them had these white matter changes. And what they found is when they tested these patients cognitively with the MoCA test, whether it was small events, large events, microbleeds, in all patterns, we saw a deficit in cognitive scoring, both in men and women. And this led the authors to say, when we consider stroke with disability, we're really looking at the tip of the iceberg of everything that's going on, whether it's small or large, whether it's just tissue changes such as white matter disease, because of all of these affect cognitive function. They went on to study this further. So these patients were then enrolled for 2 years, had a repeat brain MRI at 2 years, and they used clinical typical clinical diagnosis for stroke. And over the 2 years, 2.3% had a stroke. But if you add strokes by MRI, that went up 2.4%, 5.5%. So it was much higher. Again, all of our use of anticoagulation and everything has been based on this. There's nearly a doubling when we look a little bit closer. And so one of the arguments has been, does this really matter, the subclinical events, and are silent strokes really silent? So they took people with traditional risk of stroke, or traditional presentation with stroke, and they displayed deficits in cognitive function, memory, language production that persisted over 2 years. But what was interesting is you take the other 2% that had a silent stroke, and they had the same deficits. So it really brings up the question, is silent stroke a misnomer because we're not using the right tools to test it? And is clinical stroke is grossly underestimates really what's happening in the brain. Even if you narrow your what you consider injury down to just stroke, it significantly underestimates that. And all these trials that rely heavily on clinical stroke really need to be redone as we risk stratify patients, as we treat patients. So years ago, we started to ask this throughout Utah, and I'll share a story of a patient with mine a little bit later that led to this investigation. But we took everybody in the Intermountain Health System that had atrial fibrillation and did not. We looked at forms of dementia over time, and we've always known that atrial fibrillation causes stroke and multiple strokes cause dementia. We saw that here, but we also found that there was nearly a doubling of idiopathic dementias, both Alzheimer's and senile, and what was considered non-specific. And there was lots of scatter in diagnosis. So what we then did was narrow those patients that were seen by neurology and had a specific diagnosis, and we still found the same pattern of almost a doubling of risk. And we know men and women in general there is a predictable risk of dementia over time, and in the community, women have a much higher risk than men. But when you take the sexes and they develop atrial fibrillation, we see an acceleration of the process, but it also becomes similar. So there appears to be both sex-independent and dependent risk of dementia. But with atrial fibrillation, it may be a combined pathway that we can intervene upon. And so when we started looking at this, there was a lot of question about, is this an epiphenomenon? We're dealing with two diseases of aging, atrial fibrillation, cognitive decline, and dementia. And what was interesting to me when we looked at the relative risk of dementia in younger patients, the highest relative risk were in younger patients, less than 75. And as we extended to the older patient, the association became more difficult to see a difference. The p-values became non-significant. And there's a lot of issues that can explain this, but these trends suggested that it was more than an epiphenomenon. And the UK database went on to show the same thing using a cutoff less than 65. So our patients that are most at risk tend to be our younger atrial fibrillation patients and those that have been in atrial fibrillation for the longest amount of time. So we set up this chart trying to understand mechanisms and also perhaps ways that we could intervene with this. And one was the more common pathway that atrial fibrillation leads to micro and macro bleeds and clots. These disrupt the blood-brain barrier. You get breakdown and cellular loss, and then atrophy and dysfunction. And if this is true, then we thought that the timing, use, and efficacy of anticoagulation would be critical. And the second was related to cerebral hypoperfusion with arterial hypotension, capillary hypertension, same breakdown, same dysfunction over time. And if this pathway is significant, then perhaps the rhythm rate cerebral perfusion strategies may help. And of course, there's multiple mediators that may also intervene in genetic risk factors as well. And these aren't in isolation, but they provided two frameworks where we could start asking questions. So let's start with the first. This is data from Sweden, and there it's a nationalized health system. So they took everybody with atrial fibrillation. They looked at oral anticoagulation at baseline versus no oral anticoagulation. And those patients treated with oral anticoagulation had much lower rates of dementia over time. And they further looked at this group here by efficacy of anticoagulation. And as anticoagulation efficacy got better, the risk also got lower. And so on a population level, we saw that early and effective use of anticoagulation may be helpful. What I thought was interesting in all the sub-analyses of this work in the European Heart Journal was this trend here, where we saw the hazard ratio go from perhaps a lower risk to a higher risk, and it was all based on timing of atrial fibrillation and use of anticoagulation. And if it was started within the first year, they saw almost no dementia, whereas it delayed, then the benefit of anticoagulation was almost minimized. And we found the same thing in Intermountain Healthcare with warfarin. Early start of the risk of dementia over 5 years was almost not detectable. With later starts, we started to see this linear increase in risk. So next we ask about efficacy of use of anticoagulation and how that helps preserve the brain. And these are patients that presented to a community pharmacy service, and they were screened for cognitive function at baseline and were felt to be normal, or at worst mildly impaired, but enough that they could take warfarin, which is a challenging drug to use because it has multiple drug and food interactions, and that they would be compliant. And so no evidence of dementia at baseline and relatively cognitively preserved. And we looked at their time in therapeutic range. So normally we want an INR level of 2 to 3. And the more they're in that, the better we'd anticipate they do. So a time in therapeutic range of over 70% is thought to be a good control. But as that time in therapeutic range started to decrease from over 75 to 55 to 75 and lower, we saw risk of dementia significantly increase in almost a linear manner. And so we had the first time that we now have early start as helpful and efficacy of use and a relatively these were patients that were seen by this service on average 40 times. And we could still see this cognitive decline by efficacy of anticoagulation. So then we said, well, maybe it's just the anticoagulation. Maybe we're causing bleeds and other things. So we took people that had anticoagulation use for another reason, and we found the same pattern. Those that were on chronic anticoagulation because of valvular heart disease or chronic clots. But when we compare them to atrial fibrillation patients, there was still an augmented risk. So atrial fibrillation increased risk. It doubled to almost 4 times increased the risk compared to other types of diseases that weren't atrial fibrillation that needed long-term anticoagulation. So in all our patients that need anticoagulation, efficacy of use with warfarin is needed, but atrial fibrillation is still additive. So we have new agents. We have these direct oral anticoagulants that don't have drug-drug interactions and food-drug interactions and vitamin-drug interactions. And compared to warfarin in randomized trials, they beat warfarin every time in lowering total stroke. And so this is warfarin versus the class in general, warfarin in the dotted line and the class in general. And throughout Korea, there was a lower risk of dementia. And whether it was dabigatran, rivaroxaban, or apixaban, there was a reduction in risk over time of dementia with more effective anticoagulants. And we found the same thing throughout Utah, but in much smaller numbers than the Korean registry. And so what was lacking, though, was prospective randomized trials. And 2 came out, and they were designed in a similar fashion. One was the Giraffe trial, 200 patients over 60 years with follow-up of 2 years. And it was a comparison between dabigatran and warfarin. And they underwent cognitive battery testing every 6 months. And they found no patients developed dementia. And cognitive testing was similar or favored warfarin. So there was no benefit in a randomized controlled trial. At the exact same time, and unbeknownst to us, we did the same trial with dabigatran versus warfarin because we had a signal of dabigatran being particularly effective in our communities here. And we've said our study was designed as a vanguard study, the cognitive atrial fibrillation study, and we wanted to see if we had enough signal and understand event rates to move to a full study. And so this was a study of approximately 120 20 patients randomized to dabigatran versus warfarin with serial MRI testing, clinical follow-ups, and also a number of biomarkers looking at thrombosis and brain health. And we also were interested in the interplay with ApoE as far as a genetic predisposition towards dementia. And what we found, dabigatran versus warfarin at baseline in 24 months, no matter what scale we used, we couldn't define a difference in outcomes as well. So just like the giraffe study, we found no difference in strategy. We didn't see a preference necessarily towards warfarin, but based on these results, we didn't move forward with the larger trial, as it did not seem, we felt it would be futile or would need massive numbers. And when we looked at all these biomarkers over time, I don't have the normal ranges here, but we didn't see any difference in any biomarker of thrombosis, vascular health, inflammation. Everything was similar between the groups. So our conclusion was either strategy that was effective and used effectively, it can be used to try to minimize risk of dementia, recurrent stroke, or incident stroke in patients with atrial fibrillation. But what we do know is outside of trials and in real life, we have a problem with use of anticoagulation in the community. And as that adherence goes, then the risk of stroke goes up substantially.
Okay.
Oh, it could be anywhere 50% and higher.
So we actually,
What's that? Oh, maybe it's
It might be, yeah, you're talking about a Zoom audience.
yeah. So
And the audience gets on speak.
got it.
If it's not up there.
I was hoping he would add to this study. I was really excited. This is a huge study of 93,000 people. And this is one of the challenges when you look at observational trials versus randomized prospective trials. Is oftentimes the randomized prospective trial has the best adherence that we can achieve in motivated patients. So there still may be a role, particularly with patients that are non-compliant, non-adherent. But it's whether it's warfarin or the direct oral anticoagulants, non-adherence is a big problem, and it increases the risk of brain injury. And what's interesting is when you take people that start to develop mood disorders, and mood disorders are very common in atrial fibrillation, in particular depression. And patients that have depression, history of depression, they have much higher rates of cognitive decline, dementia, and Alzheimer's disease. And what's interesting is when we did a landmark study, almost all of that is driven by their adherence to anticoagulation, whether it's poor time in therapeutic range or adherence to direct anticoagulants. So how our patients are doing over time with using these drugs, how they're doing mentally with use of these drugs and their chronic condition can have inroads in how they're going to do. So a lot has been made of these new devices, these Watchman tools, which you plug the appendage where most of the strokes occur. 90% of the strokes occur in patients without rheumatic heart disease. But when we take these tools in aggregate, and the best data coming from the Watchman trial, which was approved first, the risk of ischemic stroke is anywhere from 2 to almost 3%, which is much higher than the risk of ischemic stroke with any of these new agents. Risk of bleeding is lower, but these patients have to remain on antiplatelets therapies, even if this is perfectly sealed. So we're still waiting to do some of the cognitive testing in this group. But I'm not optimistic based upon macro events that are almost doubled compared to our current better anticoagulants. There is one approach to the appendage that is lowered stroke, and that is surgical removal. And in this randomized trial, the Laos 3 trial, they compared occlusion versus no occlusion, and they found almost a halving over time of risk of stroke. But what's really interesting in this trial, it was not a trial of occlusion alone. And these patients at 3 years, nearly 3/4 of them were still on anticoagulants. So very similar to what we see in the population in general. So this was really a trial of anticoagulation and occlusion as a combined strategy. And when it's combined, it lowers risk of stroke significantly. The question that I have then with these tools is, can we get by with a lower anticoagulant? Can we lower risk of bleeding and take advantage of the combined therapy? Those trials still need to be done, but there's a couple companies that have interest in this, so I'm hopeful they'll get done. So I've talked a little bit about this, where I think we we show some population dating on the timing, use, and efficacy of anticoagulation. And at least in randomized control trials, that when anticoagulation strategies are used equally, that we see very low rates of dementia and cognitive decline, even when we're specifically looking for that. Let's jump over to this other paradigm of rhythm rate and cerebral perfusion. And we've been trying to improve outcomes for a long time with this. So this is the Affirm trial, and almost every primary care doctor, when I talk about rhythm control strategy, will mention the Affirm trial. And this was a 4,000 person trial in which they looked at rhythm versus rate control to see if it could improve mortality and stroke, and it did not. And so it led to the thought that it doesn't matter what you do as long as you anticoagulate them. But one of the challenges with this trial in the rhythm control group is you can see anticoagulation use significantly tailored off as people perceived that it was no longer needed. And as that went up, then the stroke rate increased. And so this really brings it raises a significant problem with the interpretation of this trial is the gross underuse of anticoagulation in one arm. Another trial in this space was the A5chf trial that also showed no changes at all. And anticoagulation, just like before, went down in patients in rhythm control. And when that happened, there was no benefit with rhythm control compared to rate control as far as stroke went. So these trials have really driven our approach to stroke for rhythm management in patients with atrial fibrillation. But we have newer data. This was data that we wrote an editorial on about a year and a half ago. And this is called the E-State AF-NET trial. Not the best trial name compared to the others. But it was a trial of early anticoagulation or early rhythm control. So every patient had to be in atrial fibrillation for a year or less. And it wasn't necessarily a trial in rhythm control of ablation, it was a trial of multiple drugs. And ablation here in blue being a small percentage of that. And they really were adherent to these strategies over time. But in this trial, rhythm control won. So rhythm control used within 1 year was effective. And even lowering, sorry, this is a little bit small, it almost lowered stroke rates at 2 years by 1.5%. But what's important in this trial is anticoagulation use was over 90%, statin use was over 90%, blood pressure medication use was over 80%. So these patients were treated for the systemic diseases that cause atrial fibrillation and also drive stroke rate. So in this trial, I think we could suggest that early management is important, but also comprehensive management is important. When it's done, then we can see some of the benefit of rhythm control. So this is a patient of mine. The first patient that made me start to question this was a patient that I admitted that was a salesman, and I could see his rhythm behind him on the screen. And he told stories. So he'd be telling his story, and then all of a sudden he would go into fibrillation, he would stop. And his wife would then fill in the story because you'd heard it 100 times. And then he'd go back to sinus and he'd say, I had a senior moment, just start talking. And this patient couldn't be explained by that first pathway at all. There has to be something else that was acutely affecting his brain. And we often see this in patients with atrial fibrillation. They say, I just don't process as well. I feel slower when I'm in fibrillation. And this is another patient of mine, and this is his monitor over 24 hours. So there are periods of time where his heart rate's in the low 20s. There's periods of time when it's over 150. There's periods of time where it's 70 to 100. So his brain, his kidneys, all of his functions are all of his organs are seeing this wide variation of perfusion. And this is what it looks like when you model it. So this is typical perfusion on a microvascular level. And most of the time it's quite predictable. 5% of the time there's hypotension, 5% hypertension, but most of the time you're in this normal predictable level. But when you're in fibrillation, about 30% of the time on the arteriolar level, you're hypotensive. And about closer to 10%, you become hypertensive on the capillary side. And how does that affect the brain? That's an area that we're trying to understand. And this is what it looks like over graphed over multiple beats, where a normal rhythm is here in blue with some R-to-R variability, which is normal. But you can see the atrial fibrillation patient all over the place. And we started to look at that, particularly we were concerned about in this patient, this, because we often with atrial fibrillation, when we're not pursuing rhythm control, try to make the heart rate look normal. Is a normal heart rate 60 to 70, let's push atrial fibrillation to that range. And when we looked at intermountain, everybody that had persistent atrial fibrillation with serial monitoring, Holter monitor, when we could average the heart rate, when the heart rate was pushed lower and lower, whether it was intrinsic because of other diseases or by medications, we started to see more cognitive dysfunction. And we did ROC curves and really found that when we were pushing heart rates below 72, that's where we started to see a higher risk. And we approached some pacemaker companies. Should we start? Because when we put a pacemaker in, we often set the lower rate at 60. And is that a good setting? We don't know. Should it be 70 or higher? Those are things we need to ask. But at least with the observational data, there may be harm when the heart rate gets too low and we're exposing the brain and other organs to these long periods of hypotension. This is what it looks like with CT perfusion imaging of the brain. This is somebody in atrial fibrillation, sinus rhythm. In atrial fibrillation, it's lower in the superior frontal lobes, but particularly in the infralateral lobes, there's a marked decrease. And in these patients that had an AV node ablation where we disconnected the atrium and ventricles, then it would normalize. And so we can measure that. And I'll show you some other images of that. This is what led to some of the work that you guys participated in. We used Robbie's dog model of atrial fibrillation, of pacing-induced atrial fibrillation. And the dog is unique and is actually quite a good model to study this because they have this vascular network in their neck that allows for cooling, but it also entraps clots. So we have a model in which we can study relatively independent the effects of perfusion on the brain in atrial fibrillation in relatively healthy animals compared to without worrying about stroke clot. So what we looked at was cerebral reserve assessment and how the brain can compensate. And we would take the dogs at baseline and then give them Diamox, which causes dilatation. It really gives a sense of the reserve of the brain to adapt. And this is a normal response. What's really interesting in dogs, so normal response here in the gray matter, the white matter, at 3 months, the response is completely maladaptive and abnormal. And then at 6 months, you get a partial recovery, but it never comes close to the initial perfusion of the brain. So in these animals that were relatively healthy, we did not see a correlation with ejection fraction or heart failure to explain some of this. We saw this maladaptive response. And we see this over and over with patients. They go into fibrillation, they have a lot of, those that develop symptoms have a lot early, then over time they become less because there's some adaptation. So is there more evidence for rhythm control? This is a human equivalent. This is MRI perfusion imaging, looking at sinus rhythm and how the brain looks, the gray matter, the white matter, total cerebral perfusion. And then in atrial fibrillation, you can see in all areas there's a decrease. This is what it looks like. So these are patients in atrial fibrillation, and they underwent a cardioversion to restore normal rhythm. And if it was unsuccessful, there was no change in brain perfusion. But in patients in which the cardioversion was successful, you can see a marked increase in perfusion, particularly in these infratemporal lobes. And it can be shown here graphically. So we can see acute evidence of improved perfusion in the brain in our patients with atrial fibrillation. So does it matter? We looked at patients throughout Intermountain Medical Center that had an ablation, our most aggressive rhythm control approach. And we took patients that had no history of dementia in any of these categories. They had at least 3 to 5 years of follow-up. There were 4,000 of those. We compared them against patients without an ablation that we weren't that interested in necessarily because you get referred for a procedure for a reason. You're often selected because you're more healthy. But we're very interested in the control group where we couldn't see any evidence of fibrillation at baseline or over the follow-up. So, and they were matched 4 to 1. But you can see in general that atrial fibrillation patients that aren't ablated are sicker. But what's interesting for stroke rates over time, that the ablation group did much better than the non-ablative group, which we expected. But the survival curves, and you can see we're out towards 10 years of stroke after an ablation, were very similar than the no-AFib group. And these rates were almost identical to the randomized controlled Cabana trial, very infrequent events. And so these patients are behaving more like the group without atrial fibrillation. And in regard to dementia, Alzheimer rates were similar between the ablation group and those without, and other forms of dementia were as well. So, and again, this has all the issues of an observational trial, and we're missing things that are subclinical. But it was interesting that the group trended so much towards the group that never had atrial fibrillation that we thought it was quite interesting. And others have gone on to do this, group from Thailand, group from Korea, and our group, all showing in aggregate that those that underwent an ablation compared to those without had much lower rates of dementia over time. And this led to a recent study from Korea, and they said, well, one of the questions is subclinical stroke. Are we just missing clinical stroke? And how does that interplay with dementia risk after an ablation? And they found the patients treated with an ablation, aggressive rhythm control versus medical therapy for it, still experienced much lower rates of dementia. And that persisted even when we consider stroke. So both incident stroke, history of stroke, incident stroke during follow-up, there was still lower risk of Alzheimer's and vascular dementia after an ablation. And this is data that we just presented and we're submitting to European Heart Journal. This is the US data. So this is the Optum claims database. It's 55,000 patients showing dementia compared to antiarrhythmic drug therapy. Catheter ablation compared to antiarrhythmic drug, significant lower rates of dementia. And we found that that pattern persisted both in men and women. But what's interesting is then we went and said, well, let's just look at the last 10 years where we've used direct oral anticoagulants more often, because these can include warfarin as well. And also we have newer ablation techniques. We found the same pattern and slightly greater diversity of the trend curve. So the benefit is still persisting even when we evolve to using newer and more effective novel anticoagulants. And this is some data to add that I think helps explain why. So these are patients that underwent an ablation, and what we did at what was done at 3 and 1 year was they did MOCA testing and they tested them cognitively. And after ablation in blue compared to red, we can see that mental function improved, or cognitive testing improved, and it improved whether you'd had a prior, whether you had prior cognitive deficit or not, whether you were young or old, whether you had paroxysmal persistent atrial fibrillation, or whether you had a prior stroke or not. So in almost all areas, we saw an improvement. I think there's a little bias in this study. Is typically when you repeat cognitive testing in patients, they do a little bit better because there's some recall in cognitive testing. So this usually goes up a little bit, and that's an important limitation, but you can still see this improvement in this group. But I thought the most intriguing part of this study was where it improved. So blue improvement here, and the control group red deficit here, deficit below the line of 0. And there was small improvements in all the domains, with the major benefit occurring in short-term memory. So it's putting some of the links together of cognitive decline, dementia, where were temporal perfusion improvement, and also where in the memory domain that we specifically test over time after ablation. So what about people that can adapt? So we know that, again, when you go from sinus rhythm, and you see here the normal pulsatility of the heart, you go into fibrillation, you can see how marked and variant it is. Normally the brain can adapt. There's the circle of Willis, and there's extensive ways to get to the brain and adapt. But what happens when you have focal disease rather than the basal artery, the carotid arteries? And what we see in that pattern, patients that have atrial fibrillation and carotid disease, independent of stroke, tend to have much higher rates of dementia, and the rates of stroke over time are also increased as well. And the groups that have the lowest risk, and the group that has the highest risk of cognitive decline, tends to be the group that benefits the most with aggressive rhythm control. So those that can adapt seem to do a little bit better with rhythm control compared to those that cannot. So we've talked a little bit about timing, use, and efficacy of anticoagulation, how rhythm rate and cerebral perfusion strategies may impact risk. But I think what the area now is how can we make a difference? And we know, you've been involved in this, with coronary disease, we know it's a gradual and progressive process happening over decades of time, ultimately reaching a critical burden in which you get disruption of the endothelial lining and you end up getting an infarction and a heart attack. And for the interventionalists, you know, they don't necessarily use disabling MI and death as their endpoint. They're using now all sorts of other tests to prevent this. And again, we've been using atrial fibrillation and we've been using disabling stroke and death. And can we use markers that can help us identify patients at risk so we can prevent this better? We've used the CHAD score for years, but unfortunately the CHAD score, which is derived of age, hypertension, diabetes, stroke, female sex, heart failure, vascular disease, it really predicts at about a 50 to 60% accuracy. And so can we take biomarkers of health that can be measured as you get serious about weight loss and you lower your hypertension, you minimize your hypertension, diabetes. Can some of these things be reversed? Right now, this is a static score, and once you have hypertension, you always have hypertension. But when we add markers, whether it's the complete blood count, the creatinine, how it changes over time, we can stratify across all categories of low, moderate, and high risk patients at risk for dementia using AI. And what's really interesting, and I unfortunately don't have this work, but we've always wondered what's the point of no return. And at Intermountain Healthcare, you could go back 20 to 30 years and look at this. And what we would see is the body would adapt, and there would be a period of acceleration of disease. And that period is critical for predicting much more than this. And that we were doing it with a team of AI engineers, but they left ICE and formed their own company. So some of the things are coming out in probably a proprietary manner. But if you're interested in that space, it's really interesting to watch the body adapt, and that loss of an adaptation from a biologic risk assessment is really critical. This I find really fascinating as well. I published this in JCI a couple of years ago. And if you just take red cells, we know red cells are typically in this normal bell-shaped curve. They fit quite nicely, but there's some that are small, some that are large, and that often reflects systemic disease. But if you take some of these blood count, and does it look small? And what's the percentage of it being large and small? Does it look like this? Does it look like this? When you just look at those cells, you can predict across the Intermountain medical system in almost a linear manner who's going to do worse. Who's going to do worse with a dementia? Who's going to do worse with stroke? Who's going to do worse with risk of recurrence after an ablation? Just taking blood cells and looking at them. And the risk prediction is so much greater than what we're currently doing with the CHAD score. So I think there's a lot of excitement and interest in AI and these domains for risk prediction using massive data. Anyway, that's all I have for you. Thank you very much.
Thank you so much.
My pleasure.
We'll have questions both online and in the room here. Go ahead and open it up.
Go ahead.
Yeah, so just to play